So I'm going to be discussing the topic of infected non-unions. You see a new term up there, which is now called fracture-related infection. So what we are going to be looking at is this whole terminology of superficial, deep, acute, chronic is kind of changed because this is a continuum of process. There is really nothing such as superficial, deep. It tends to go in various layers, and this therefore has been replaced by the term FRI or fracture-related infection. And these are two links which I think are very useful for anybody who's interested in this. The first is a bunch of AO videos and webinar recordings in relation to the FRI. And the second is some publications which I will show you in a bit. So these are the four really useful papers, I think, found at that link which I told you. You can see the link over here, which I think anybody who's interested in infection, which all of us should be, should read. So we'll talk about the treatment strategies for FRI. And in that, I think the two main things, especially in relation to infected non-union, is one, prevention, and second is the treatment of infection, either eradicate it or control it. The healing of the fracture per se is a bunch of concepts in terms of what is needed for healing, and that's the same as an aseptic, that is alignment, stability, and contact. Whenever we do a non-union, we are looking for absolute stability, and then the biology and maintenance of the function. I think there are some important habits to inculcate in terms of prevention of early infection. And these are, one, only to use perioperative, that is a short time, 24 to 48 hours of perioperative IV antibiotics, and then no antibiotics. Treat internal fixation as carefully or as gingerly as you would a knee replacement or a hip replacement in terms of the importance of asepsis. Open fractures should be debrided thoroughly. We always say radical debridement, but I think sometimes the execution of that term, radical debridement, is not appropriate. And remember to take a swab after the debridement, because that's the bug which will usually cause the infection. Out of all of the various antibiotics which are there, again, following up on the importance of debridement, a scalpel is the best antibiotic in an open fracture as well as in early infection. Avoid these ascending ladder antibiotics, trying to reach to the highest antibiotic to try and get control on the infection. If you are in doubt, I think it's always a better idea to open, debride, and lavage the incision. So there's a very good diagnosis algorithm in this paper. This is freely available on the net, and you can go through that. I will write down some of the points that they have made. As to when should you go in for surgical exploration, whenever you have a confirmatory sign, which is a fistula, a sinus, or a wound breakdown, a purulent discharge or frank pus. The other things which we normally call signs of infection, they have classified as suggestive. That is the clinical signs of redness, fever, radiological signs, inflammatory markers, out of which I think the CRP is really the most important. A new onset of a joint effusion, and wound drainage, which is either started newly or is increasing or is persistent. But I think the bottom line is that you should have a low threshold for the suspicion of infection. After you've done a surgical exploration, you will get some material for culture, etc. And if you've got pathogenic bacteria from at least 2 of the 5 sites that have been sampled, or if you find microorganisms which are confirmed by histopath, in the deep tissue. Or if you get 5 polymorphonucleus per high power field, again confirmed by histopath, then these are confirmatory signs. But even if you have a suggestive sign such as bacteria isolated only from one site, in combination with other suggestive signs, you should carry a high suspicion for infection. And here is the importance of what's known as a MDT, that is a multidisciplinary team. For proper identification of the organism, you need the microbiologist on board, because today there are identification tests for identifying the organism as well as the resistance pattern beyond culture, which they are able to help us with. So this gives us the organisms as well as the resistance. Remember that patient should have an antibiotic-free period before you harvest the samples. 4 to 5 tissue samples from different areas. And when you're doing that, again, if you are in consultation with the microbiologist or in cooperation with the microbiologist, you will ensure that you have enriched media available in the theater. One thing you should remember is the OT2 lab time. There's no point in getting a sample at 4 in the evening and then it reaches the lab next morning at 10 o'clock. These cultures should be plated as soon as possible. And we do have a lot of polymicrobial infections. Surface swabs are useless. Suppressive antibiotics, except in very specific cases and as advised by the infectious disease specialist, I think should not be done. So the same management algorithm, there is a good article which has this management algorithm in terms of the general treatment principles, which is primarily, as I said, surgery. You should have a good debridement where you would usually remove the implant, and most importantly is the biofilm on the surface of the bone, on the surface of the implant, in the fracture gap, etc. Because this is what leads to recurrence of infection. In terms of the implant, depending on what situation you are in, you may do a removal, you may do an exchange. In certain cases, you may do a retention. There is a difference in a nail and a plate, which I'll come to in a bit. You also have to consider the issue of stability, because infection can never be eradicated in the presence of instability. So removal of implant and then put in a cast, generally waiting for the infection to settle, I would say, as a general rule, is not a good idea. If need be, you can use an appropriate external fixator. And don't forget the importance of the use of a local antibiotic depot. Depending on the circumstances, you may decide to use an absorbable or a non-absorbable local antibiotic depot. So we don't treat cardiac failure in our patients. We send it to a cardiologist. Now, I think infection has become an important issue in itself, given all the bacteria that are present and the various resistance patterns. We don't know much today about the antibiotic interactions. What is the antibiotic availability in the musculoskeletal system? That's different from what you see in the Petri dishes. And we don't know enough about antibiotic resistance, and we should be very careful that we are not encouraging the formation of resistance. So I think for all of these reasons, getting the microbiologist and the infectious disease specialist on board is very, very important. And I think today all of us know that we can do telemedicine, Zoom consultations, etc. So even in smaller places, if we are in smaller places where an ID physician per se is not available, that can be done on a Zoom call kind of thing. Now the question is, should you retain the implant or not? If the fracture is healed, then yes, you can take out the implant and just then treat it as a case of osteomyelitis. If it's not healed and you can't retain the implant, then you may do an implant exchange. And if it's a difficult to treat, that is a resistant bacteria, then you may need to go for suppression with, again, as I said, the advice of the infectious disease specialist. If it's not a difficult to treat infection, then you should go for eradication. And if implant retention is advisable, then you may retain the implant and then go down the same path. But all of this also depends on other issues. Is the construct stable? What's the time interval? Since if you are opening it up in the first week after fixation and there is infection, then yes, you would kind of retain the implant. But if you're opening it up after a year, then probably there's no point in retaining the implant. Then you have to look at other things. What is the host physiology? What is the anatomical location? Some locations are not well treated with external fixators. Is the soft tissues good? And are you able to do a sufficient debridement? All of these are important things. Now, in general, you can do this either in a single stage or in 2 stages. In the single stage, you do a surgical treatment of the infection and a definitive stabilization of the non-union, either a plate or a nail, depending on what is required for that particular fracture, or especially in late presenting cases or where soft tissues are not very good, you do it in a 2-stage, where you treat the infection surgically, do a temporary stabilization, either an antibiotic, nail, or an external fixator, review this at 4 to 6 weeks, confirm that the CRP, etc. is down, and then you can go ahead with a definitive stabilization. So in 2-stage, especially if you have an unknown or resistant organism, then it's another reason to go in for a 2-stage approach. Now, debridement, antibiotics, and implant retention, just like prosthetic joint infection, there is a role for DARE even in internal fixation. And one should know that there is a higher failure rate with a nail versus a plate. And the reason is, a plate is kind of available to us to debride, whereas most of the nail is inside, and the biofilm on the nail you are not able to take out if you retain it. The sooner it is done, it's better, and this is related to the age of the biofilm. The older the biofilm gets, the more resistant it is to the antibiotics are not able to penetrate it that well. So less than 3 weeks, there is a 90% success. More than 10 weeks, it's only a 50% success. And again, as I said, you should think of local antibiotic depot, 6 to 12 weeks of antibiotics. Currently, the general consensus is 1 or 2 weeks intravenous, and then oral is as good as 6 weeks of IV antibiotics. When you don't do a DARE is when you have a late presentation, when you have poor local conditions, organisms are resistant, and there is a length discrepancy, in which in these cases bone transport or fixator related treatments are better. So in terms of principles, I would say clearance of the infection by debridement, isolating the organisms, and appropriate antibiotics, use of a local antibiotic depot. Then the same old principles of treating a non-union: alignment, stability, biology, and function. And those links which I've given earlier, I think they will give you a lot of information. The importance of a multidisciplinary team, I think, cannot be forgotten. I mean, I must emphasize the importance of a multidisciplinary team. DARE is possible. It's not that every infected non-union needs a fixator. Depending on what the circumstances are, you can do a single stage or a multi-stage treatment. In terms of Ilizarov, we say monofocal, bifocal, or trifocal if there is a bone gap. Vascularized fibula is another way of treating a bone gap, as well as an induced membrane. But these are specific situations where there is a bone gap. Thank you.